There we are.
Yay.
Excellent. Thank you. I'm glad this worked out.
Yes, I guess you can't do it from a laptop because I saw sort of, but I couldn't join. I didn't get the message.
No worries. No worries. Thank you so much for joining on the phone.
Sure.
So I now we've got the the most important person here. So I know we're just a few minutes past the hour, so I'll hurry up and get us started. So welcome to everybody that's joined. I see we've got, I don't know, so far just over 10 people joining, so that's great, and I'm sure more people will join us as we move forward. Thank you so much. This is the first live event that Recurrent Pregnancy Loss Association has ever done, and we're really thrilled, and hopefully we'll be able to continue to do more of these throughout 2021 and even beyond that. I want to just start by saying thank you, and I'm so sorry for those of you that are joining. If you're with us, it likely means that you or someone that you love very much has experienced recurrent miscarriage. And so I'm sorry that you're joining under those circumstances, but hopefully this will be a really useful conversation to listen to. I'm Megan Hansen. I am the co-founder of RPLA. Just to give you a little bit of background, my husband and I suffered 6 miscarriages. We still don't have a child of our own yet, so we're very much still on our own journey, and so we really understand a lot of the challenges of going through this experience. We formed Recurrent Pregnancy Loss Association, which is a patient-led nonprofit organization aimed at providing educational resources, support, and also for families. And also we want to really raise money and help fund research so that we can get better answers and information about the causes of recurrent pregnancy loss and potentially then better treatments. So I will stop talking here and very quickly hand it over to Dr. Winifred Mack. She's been advising us throughout this year and has been a huge asset to our organization. She is a renowned expert in the field of recurrent pregnancy loss, a researcher and clinician at UT Austin. And what we'll do for this hour is just, I got a lot of questions submitted from our followers. And so Dr. Mack and I will just have a conversation where she answers the questions that you all submitted to me. But before that, Dr. Mack, why don't I ask if you can just introduce yourself a little bit more, give us a little bit of your background, the research that you focus on, and how you got into this space.
Sure. Well, thank you for inviting me. This is my first Instagram live, so I'm glad to impart any information to patients. That's kind of my goal and why I'm here. So a bit about me. I am from England, and I am a reproductive endocrinologist and infertility specialist. I am at UT Health Austin, and I chose to take care specifically patients with recurrent pregnancy loss because from a research point of view, there is so much that needs to be done in this for recurrent pregnancy loss. We don't know too much about sort of causes, and so that made me think that I want to take care of patients who have recurrent pregnancy loss. And so my journey started probably about 3 or 4 years ago when I was at Yale, and I was a director of the Recurrent Pregnancy Loss Center there. And I got involved in a charity called Hope After Loss, which is a peer-to-peer support group for those who have losses. And really that's kind of where I started sort of being involved with pregnancy loss and recurrent pregnancy loss. And my research interests have really sort of focused on that most recently. And I have interest in the placenta. So, you know, pregnancy, placenta is so important. So that's a major interest of mine. And I got a small grant to study more about miscarriages. And so we're doing some really early studies of actually making stem cells from miscarriage placenta so that we can really study the molecular basis of why some miscarriages happen. And so that's kind of where I'm at right now. And my goal at UT Health Austin is really to have a place for those who've had early pregnancy losses, regardless if it's recurrent or not recurrent. You've had one. I think you just need that different sort of care that, you know, people like I can provide. And then once you're sort of past the time that you've lost, I can hand you back to your OBGYN who can take care of you from that, because I don't do deliveries anymore. So that's kind of what's been my goals for our early pregnancy center.
No, thank you so much for sharing that. And you know, you mentioned early pregnancy losses, whether it's one or whether it's multiple. Maybe if you could just, when doctors talk about recurrent pregnancy loss, can you just kind of frame set what specifically, give the kind of background of what does that mean? And just which couples should be evaluated for underlying conditions of recurrent loss versus early pregnancy loss that is much more common.
Sure. So unfortunately, miscarriage is one of the commonest complications of pregnancy. So between 15 to 20% of couples may experience at least one pregnancy loss. And recurrent pregnancy loss in the years past was defined as 3 or more losses. But we know from research that even having 2 losses, you're at still increased risk of having another loss. So really the societies in Europe and here in the US have changed the definition of recurrent pregnancy loss as 2 or more miscarriages. And so this is pregnancy loss are defined as under 20 weeks. So if you had a loss under 20 weeks, that is a pregnancy loss. So basically 2 or more is what is now generally accepted. There are some slight differences between the Europeans and the US regarding whether biochemical pregnancies are included or not. So in the European definition, they include any pregnancy, whether it's biochemical. Sort of the timing is not so important, whereas in the the ASRM, the American Society of Reproductive Medicine, define it as a clinical pregnancy, where there's either ultrasound or you actually have miscarriage material that you've passed to define it as a pregnancy.
Yeah, and I think, you know, I think that's so important, because I don't know that I hear from a lot of women that are going through this, like, oh, well, my doctor says I can't be evaluated until I've had 3 losses. And that sort of changing definition to say, oh, well, the research is saying now that it's 2 is really important. So I think that's a question that a lot of women and couples deal with, is when should I get evaluated, and who is the appropriate care provider to do that initial workup and evaluation? So maybe you can speak a little bit to that.
Sure. So usually most people, if they've had 1 miscarriage, their OBGYN takes care of them. By the 2nd miscarriage, they usually refer to a reproductive endocrinologist and fertility specialist, an REI. There are centers around the US that they call themselves recurrent pregnancy loss centers that deal with the immunological, but they are usually OBGYNs, but and not REIs. So during REI training, during fellowship, we are trained to take care of women who have recurrent pregnancy loss and do a standard workup. So the standard workup is nothing unique to us. So a general OBGYN could also do the same workup. There is nothing specific that we necessarily, that a general OBGYN couldn't order in that general workup. But mostly, I would say that OBGYNs would refer someone who's had 2 miscarriages to a reproductive endocrinologist.
And just to make sure that can you just walk through what is that standard first workup, whether it was done by an REI or if an OBGYN was doing it? Yeah.
Sure. So the ASRM, the American Society of Reproductive Medicine, they have a bulletin that lists out the standard workup. And so this is looking at the chromosomes of both mom and dad. So that's a carrier type for mom and dad to see if there's any genetic reason that there may be a flip chromosome in either of the parents that could lead to recurrent pregnancy loss. Other things are to check your thyroid because we know that hypothyroidism can be a known cause. If you're having irregular cycles, prolactin is sometimes checked to see if you have something sort of too high prolactin levels. Mm-hmm. If you may have prediabetes or diabetes, to check the hemoglobin A1C to see if you have uncontrolled diabetes, because that can lead to increased risk of miscarriages. And then there is other blood work that looks at thrombophilias, which this is the increased clotting disorders. And there's one particular one has been well studied to be associated with recurrent pregnancy loss, and it's called antiphospholipid syndrome. And there are 3 different blood tests involved in that that can be tested, and there are certain levels that basically you have to have high levels in one of those 3 tests, and it has to be repeated 12 weeks apart. So if you have 2 positives, then you meet the criteria if you've had that blood level and 3 or more losses. So they have, to fit antiphospholipid syndrome, you have to have at least 3 or more unexplained early pregnancy losses or a later loss, and the lab values as well. So it's very specific on the definition. And then it's to look at the uterus, to look at whether there is something called a uterine septum, which is like a wall inside the uterus cavity, or if you have 2 separate uterine cavities, that's uterine didelphys. And also to look at inside the cavity, do you have any fibroids, such as submucosal fibroids, where the fibroid is pooching into the cavity and deforming the cavity. Sometimes we can see polyps, which are little balls of endometrial tissue that forms a little ball inside the uterus, and that could be associated with miscarriage. So we're looking for any structural issues inside the uterus that could be leading to miscarriage. And so that is what ASRM had, the standard sort of, these are the things that we should make sure that you don't have. And so that's kind of the sort of standard evidence-based workup that most insurances will only cover as well, because we can get into insurance, but there are certain things that the insurance won't cover that could be informative as well.
Well, no, and I appreciate you going through it, because I think it's like, and we'll move into that unexplained category, which is where a lot of people, I think, have questions. But I think it's important to talk about, well, what's the kind of standard workup? Because even a lot of women are working with care providers maybe that aren't even going through that full standard workup, that have had multiple losses and haven't had a uterine cavity evaluation and things like that. So I think it's important to kind of list, like, for everybody to know what's the, like, let's make sure that all these boxes are checked. But realistically, I think what I experienced, and I know what a lot of people came with questions, is like, well, all my tests came back relatively normal and I'm still having losses. So now what? So I don't know if you can talk, before I ask questions about that, like, what's the prevalence of women that go through that standard evaluation, end up without a real cause, and what is the prognosis for them? Like, what's the likelihood that they'll be able to move forward and have a successful pregnancy?
So we think that maybe up to 50% of couples, we will not using what the standard workup that I've just mentioned, will not uncover anything. And so therefore, that's why when I say the standard workup, you know, we might find 50% will have one of these issues. There's the 50% that, despite all those testing, everything is negative. However, then you can move on to other sort of tests that haven't made it into the ASRM category, that, you know, there is definitely associations with recurrent pregnancy loss. And I think that bulletin came out in 2012. And so hopefully there will be some revisions to that shortly. And I would say that in Europe, the equivalent society have come up with some newer tests that, and we can talk about this later, but male factor has sort of become part of the standard workup in Europe as one of the things that should be done. But in the ASRM bulletin, they really don't sort of talk about the male side, what we're going to do to check out a male factor. And so also, even though pregnant, you know, it seems for, you know, couples who've had multiple pregnancy loss, a pregnancy will never happen or a live birth will never happen. We know when people have looked at sort of over time at couples with recurrent pregnancy loss, that even if you have 6 pregnancy losses, and obviously it depends on your age, that those couples would still, 50% would still go on to have a live birth. So, you know, I think that there is still hope. And I tell my patients that, you know, there is hope. However, you know, we don't know how many miscarriages you'll need to go through to get to that baby. And so I think that maybe obviously the most difficult part is just, yes, you're telling me I'm going to have the live birth, but, you know, is my next miscarriage going to be another miscarriage? I mean, my next pregnancy going to be another miscarriage? You know, I would say that once you've had multiple miscarriages, yes, you're at increased risk than someone who's not had a miscarriage. However, it looks like that, you know, when they looked at people who had, you know, sort of 3 or more and even up to 6, those people just took longer to have the baby, but they did still have the baby, if that makes sense.
Yeah, it's the chances are still in our favor. It's just there might be more pain in getting to that eventual endpoint. Yeah.
Right.
Thank you. And so then you mentioned, you know, additional diagnostics beyond the standard workup. Can you talk about, in your practice, are there additional diagnostics that you're offering routinely to all your patients? Or when you look at those additional diagnostics, are you applying them more specifically based on the couple's background? Like, what other steps do you take and why?
Sure. So I definitely, so with the urine evaluation, which I do a saline ultrasound, and that's pretty standard. I do an endometrial biopsy to check for something called chronic endometritis. And so this has been shown by several groups to be associated with recurrent pregnancy loss. So I know I'm talking about associations because basically to really say something is a cause for recurrent pregnancy loss, we have to show the mechanism of, yes, this thing you have for sure, led to your pregnancy loss. A lot of research in pregnancy loss, unfortunately, is association. Like, oh, we found, in this recurrent pregnancy loss group, there is 50% likelihood of having chronic endometritis versus a control group that, did not have recurrent pregnancy loss. But does that mean cause and effect? We don't know. However, there is some smaller studies which have shown that if you treat chronic endometritis with antibiotics, that could be helpful to increase the chances that the next pregnancy will be an ongoing. But there has not been a large randomized control trial to show that there has been an increase in live birth rate. So these are smaller studies. So an endometrial biopsy is uncomfortable, but it's not a major invasive, severely invasive testing. So I do offer it standard to my patients. And then if I find chronic endometritis, I do a 2-week course of antibiotics. And then we repeat the biopsy to make sure that the endometritis has gone away. So that's one test that I think that a lot of practitioners are doing. And chronic endometritis has also been related to recurrent implantation failure. So where infertility couples are struggling to get pregnant, and say if they do IVF and they're still not getting pregnant, some people have linked that potentially as a cause. Mm-hmm. And then another test that I now offer to patients is to look at the man. And I do send my my male partners to have a semen analysis because there has been shown that male partners of recurrent pregnancy loss patients can have abnormal motility morphology parameters. Mm-hmm. So that's, there is an association there. But another test that I've been now more routinely offering, because the Europeans have decided that should be part of the standard workup, is something called sperm DNA fragmentation test. And this looks at the integrity of the DNA of the sperm. Okay. There are many different ways to test that, and we won't go into sort of all the different tests that are available, but various studies have shown that there is a association between increased sperm DNA fragmentation and recurrent pregnancy loss. I think we definitely obviously need to study it more to see if it is a cause, but there is definitely something there that in the male that is not quite right, that is associated with recurrent pregnancy loss. And we know from mouse studies that DNA fragmentation, which is such as double-stranded breaks in DNA, can lead to abnormalities in not getting pregnant or issues with the embryos. So there is, from animal models at least, some information suggestive that double-stranded breaks in sperm could lead to pregnancy loss. And so I think that, again, we need, and I'm sort of toying with the idea of writing a grant where we will recruit many recurrent pregnancy loss patients, because most of the studies, the largest study looked at 111 recurrent pregnancy couples, but I think if we can get into 400 or 500, we can really see if there is an increased risk, because the more people we have, and because recurrent pregnancy loss is not super common, which is a good thing, we just need a large number of participants to really, see, because these prior studies have been very different. Like, do you include people who have just 2 pregnancy losses or only 3, and there's a lot of heterogeneity between studies. So it would be very nice to have one really large study where we have 400 or 500 patients and look at DNA fragmentation and see if there is a difference, and how many of those patients have abnormal versus fertile population would be kind of the ideal study. So I think that study would be a relatively easy study to do, because it's not super invasive to give a sperm sample,
Yeah.
and it'll give a lot of information.
And I think, some of the feedback that the organization has received is that there would be a lot of interest from the community in participating in studies like that. So I think probably we can have a whole future conversation just about those types of things. So as the endometrial biopsy, you said if you would treat that with the course of antibiotics. With the DNA, the sperm DNA fragmentation, you mentioned that problems with the sperm could cause problems with the embryo that could lead to miscarriage. And I think that's a common frustration I also hear from couples that have had multiple losses, is that kind of standard answer of oh, well, it was probably that there was something just chromosomally wrong with the embryo, which then leads to a lot of people saying, oh, maybe we'll do IVF with pre-genetic testing. Can you talk a little bit more about that as a therapy for recurrent pregnancy loss? When is that appropriate and when is that not appropriate? And how do you as a clinician start to make those distinctions?
Sure, that's a good question. And so the Stanford group actually did a study to look at sort of treatment to do IVF, whether that helps with recurrent pregnancy loss. And they really showed that it did not help those patients, and it took them longer to get pregnant, because a lot of my recurrent pregnancy loss patients actually get pregnant easily on their own. It's just, unfortunately, they have miscarriages. And so, doing an IVF treatment, it takes about between 4 to 6 weeks to do one cycle. So that, they already showed that, probably if you have an unexplained recurrent pregnancy loss, it probably doesn't add to the live birth rate. However, where I think it's, I would say for my patients who are having recurrent pregnancy loss, is the ones who actually have abnormal karyotype in their miscarriages. If they've had chromosomal testing and they have abnormal chromosomes in their loss, then that makes sense to potentially decrease the miscarriage by selecting a normal embryo. Also, for women who are older, we know over age 35, the reason why women are not as fertile and are going on to have babies is because the quality of the egg is going down, and they're more likely to make embryos that are abnormal, and therefore they're more likely either not to get pregnant or to have miscarriages. So in those women, you may want to think about IVF with genetic testing, because it's really an age issue and not because they have some other reason for their recurrent pregnancy loss. So that could be another group that I can see that no one has looked at doing IVF with genetic testing for women who are having recurrent pregnancy loss because of age, or if they have recurrent abnormal embryos. So I think that group, regardless of sort of the study, would probably benefit from that. But routinely for my younger patients, I do not suggest going to IVF with genetic testing, because mostly when I've genetically tested their miscarriages, it's always been normal. So I don't necessarily see the benefit of doing IVF and genetic testing. The only other reason for younger women that I would suggest it is if they truly have had unexplained, they've had 5, 6 losses, they've done all the treatments under the sun, Lovenox, everything, and they're considering potentially going down the sort of reproductive immunological test sort of treatments such as IVIG, then I would rather they have a normal embryo that was transferred before they do the sort of more investigational treatments. Mm-hmm. Because you know, if you're going to go all that way, you want to make sure that the one major reason why people have miscarriages, which is an abnormal embryo, is kind of removed from the equation. So, and really, I've only had a few patients that I've sort of suggested to go that way. Because thankfully, most of my younger patients, you know, majority just go on without having to do more, you know, like a significant intervention. So.
And I know, you know, that's something that I know is really widely debated in the reproductive specialty, is that kind of immunological component and the testing and the treatment for that. So maybe could you just give a little bit of kind of the background and context for that? And is it something that you test for or not? Is it something that if your patients are wanting to test for it or treat for it, you're supportive or not? And just talk about why.
Sure. Super controversial, but but I'll try and be very PC about it. So I think that there is a large body of studies about immunological reasons for recurrent pregnancy loss, and I think that there definitely it probably is a factor in some people. However, the testing is, you know, we're not sure if the tests that people do, which is usually on peripheral blood, whether that reads out the same as what is seen in the uterus. So basically the sort of thought is that the mother obviously will have, the baby's foreign to the mother. Therefore, you know, the woman, the mother has to adapt, you know, to this foreign sort of pregnancy in them. Therefore, there are certain things in immunologically that have to happen for that to the mother to have immunotolerance of the baby. So like not to necessarily sort of not, it's not a rejection, but there has to be a balance of certain cytokines. There are certain T cells and there's natural killer cells. It's a very complicated system that a lot of people have studied, and they're piecing together sort of, but no one has ever really studied it in humans, you know, because you can never have a model to study humans. So a lot of it has been in the mouse. And so there are tests which, you know, I have looked at the literature, which are peripheral blood tests to look at different populations of immune cells, T cells, and natural killer cells. And so there are definitely testing companies that can do the immunological testings that have been cited in the literature. The issues are sort of whether what we're testing for, is that actually abnormal or not, is the question. And a lot of people will base their treatment on those testing. So for instance, if you have a positive result on the immunological testing, there are studies which show that you know, possible treatments is IVIG, which is intravenous immunoglobulin, which is, I guess, the most talked about in these circles. And so there have been various studies that have shown that it works, and then there are studies where they show it doesn't work. So I think the ones that have shown it has worked is when they do the immunological testing first, and they do actually have certain cutoffs for abnormality, it seems to help those patients. The issues are with the studies is that it is difficult to do something called a randomized controlled trial because no one's going to be in the placebo group, i.e. do nothing. So it's very hard to interpret these studies because usually the patient is their own control. And so, you know, and also the numbers of participants are small because, you know, less than 1% of patients will have 3 losses. So the number of patients are not going to be huge. And so it's difficult to interpret the data. If you have small number of participants, you don't really have a control group where you're trying out these different treatments to really show that it's of benefit. So that's one. There's two areas of controversy: is do we have the right test to test for immunological issues, and two, what is the best treatment? Because there are, people have done steroids, prednisone. That's, the small study didn't show any benefit. So there's many small studies that sometimes show benefits and sometimes don't. And I believe, and obviously this is just my personal sort of opinion, is that it will need a personalized approach to recurrent pregnancy loss. I think we lump women who have 2 or more losses together in one big group, but everybody's probably has a different reason for why they're having pregnancy loss. It's too broad a category, and I think it will basically, as we study this more, we'll find that there'll be little groups that will have maybe this wrong and this wrong, and it's not going to be just one thing. I think it's a threshold above which, you may have this, you might have chronic endometritis, and there may be issues with the sperm that has pushed you as a couple to have more likely to have miscarriages. I think that as we know more about recurrent pregnancy loss and sort of pregnancy loss in general, and study it more, we will figure out probably that it's, reproduction is a very complicated process. And there are many ways that could lead to a miscarriage. And it's not just going to be one reason for everyone. So I think it's naive for us to think that unexplained pregnancy loss is going to be one person, it's one cause for everybody, and one treatment is going to treat all. It's probably not going to be that simple.
Yeah. So which I think is really helpful, right? So like, because you see all this online, like something that worked for one person, it might not work for somebody else, that it really does need to be kind of looking at your own personal history. Do you, and which leads to maybe asking some other questions that I know have a lot of like mixed responses, doctors, when patients are doing their own research. And one of them is about the progesterone supplementation, because that's something I know that there's kind of articles in support and articles not in support, and different evidence has come out. So can you talk about when and why you would think about progesterone supplementation with your patients or not?
Sure. So it's really interesting that I was talking to some physicians in Europe, and in the UK, where I'm from, using progesterone is like, ooh, you want to use progesterone, whereas in the US, everybody's using progesterone. So it's a very different mindset. So in the UK, they had this very large, they've had actually 2 very large randomized control trials to look at progesterone. And the PROMISE trial was to look at women with unexplained recurrent pregnancy loss and whether vaginal progesterone would increase live births. And the really nicely powered study showed overall no difference. So vaginal progesterone, when they started it with the pregnancy, so it really had no significant increase. So I think it was like 3% increase in live birth rate, and it was not statistically significant. And so the reason why they had done that study is because there has been many smaller studies that has suggested progesterone can help in unexplained pregnancy loss. And so that was the reason why they wanted to do this large study, and they obviously were surprised with the result. Because in UK, you have to get your doctor to agree to give you progesterone. It's not something that is widely accepted. So they had to do the trial to really say, hey, it is a benefit before I can prescribe it. And so it didn't show benefit. However, when they looked at subgroups, and so these are women who have 3, 4 more losses, those patients did have a small benefit. So as you got to have more losses, it looked like there was benefit for those small subgroups.
Mhm.
So they've subsequently published from the Promise trial other sort of analyses, and they have sort of suggested that probably 3 or more losses you benefit, but probably less than that, maybe of no benefit, or minimal benefit. And then, so there's some studies about sort of starting in the luteal phase. And there is one particular study that it's not a randomized control, but it's a well thought out study that really showed that luteal phase, it could be of benefit as well. And I think in my practice, at least, when the Promise trial came out, I really thought, hey, starting it with the pregnancy probably wasn't of benefit. So I really sort of flipped to the luteal phase progesterone. And now I kind of do a combo where I do luteal phase progesterone, and then I increase the dose once my patients are pregnant to the dose that is in the Promise trial, because they use pretty high doses of progesterone in the Promise trial, whereas the luteal phase is a lower dose. So I do a combo. There's no study has shown that that's a benefit, but I think in some case, sort of given that the overall, the randomized control trial didn't show a benefit once you were pregnant, and there is some evidence from decent studies that luteal phase is helpful. The reason, again, what we need to study is how progesterone can help with recurrent pregnancy loss. We think that it may be an immunomodulator. So coming back to the immunological side of things, I think progesterone is a bit more inert than doing infusions of IVIG, and cheaper. So it would be really interesting to see if progesterone could be used for the immunological issues, and that would be a really sort of alternative. Like, oh yes, you have abnormal NK cells, let's use progesterone instead of IVIG.
Mm-hmm. No, thank you. That's really that's really, really interesting and really helpful. And I'll be curious to know more about that myself as more studies are done. I think we've got about 10 more minutes left. And I know, I just want to pause and say there were a lot of questions that came in, and I know we're covering a really broad range of topics. So if we don't get to your specific question in this conversation, we'll schedule more kind of follow-up, maybe deeper and more focused conversations on some of these topics. So I'll be reaching out to get feedback from people that have joined and things like that. But Dr. Mack, I guess kind of thinking about a lot of what you've said about different tests and different, like it being more personalized. I think a lot of the frustration and a lot of the role specific questions that came back in were coming from a place of, okay, I've gotten all the standardized tests. Maybe I've even tried IVF and had some implantation failures or had some miscarriages, after doing a successful IVF transfer. Maybe I'm doing all of the Lovenox, I'm doing all of the drugs, and it's still not working for me. And now what do I do? And that's where I think a lot of women get into, am I seeing the right doctor? Am I enlisting the right specialist? Am I taking the right supplements? Like, what else can I do to help control the situation? And so what do you recommend to kind of all your patients, and then what do you recommend specifically to your patients that are kind of continuing to go through the rigmarole of medical intervention without seeing the success as quickly as they'd like to?
Yeah, that I know it's very frustrating, and obviously going through miscarriage after miscarriage is just terrible. And because I see these couples, I sometimes have to tell patients, we just sometimes don't have the test for you. You just have to be honest. Yeah, I can go through all these things, and we can, do every single thing under the sun. And so, you asked me about the immunological testing. When I offer it, I really offer it once the patient either comes to me asking for it, or we've exhausted everything, and I say to them, hey, it's controversial, but if you want to do a test that, potentially maybe we'll find something, then we can do that, So I think we just don't have all the answers, and we just have to be honest with patients that we just don't have the answer for you, even though we've done everything. What I would say is that I hope that, so recently the NIH asked for grants to be written for genetic causes of early pregnancy. And I hope that, sort of one of those studies will be involved in sort of genetic testing, very extensive genetic testing of couples with potentially recurrent pregnancy loss, so that maybe we can identify some risk factors genetically to get more answers. And I think that's where I was excited to join the RPL Association, is to really help in the sort of getting the word out. Hey, we just need more research in this area, because since 2012, apart from those standard tests, we've had a couple, the chronic endometritis, the sperm DNA fragmentation, but that's 8 years ago. And I, still don't have a new, standard other testing that I can offer patients, to figure out why they lost. Another thing I have been doing sort of clinically is, Yale is one of the genome centers, and so what we've been doing when I was there is, for the patients, apart from doing chromosomal analysis, we've been doing exome sequencing, which is actually looking at genes to see if there's anything else that, genetically, that is causing the miscarriage. So I think we just published a paper on that, and after doing the exome sequencing, definitely 20 to 30% of patients, there was actually something else wrong, apart from, because these were all normal chromosome miscarriages. And so I think that, maybe studying more in depth the genetics of miscarriages, we may find that maybe a lot of them are actual genetic issues that are not just the chromosomes, and actually single genes. Mm-hmm. So as genetic testing becomes much cheaper, hopefully we can offer those testing as a standard to, yes, a miscarriage, we can do the chromosomes, and if it's normal, then we can do exome sequencing as well to see if there's anything else that we can look at that potentially could give us an indication that this could be genetic. And if it's a rare, happened once, then hopefully it won't happen again. However, if either of you carry the gene, or both of you carry this gene, maybe we can do IVF and genetically test your embryos. So I think until we study, actually do those testing, we won't know if that's a reason. But my suspicion is that we'll probably pick up a 20 to 30% more of patients from that it is a genetic reason, but not just chromosomes. So I think that will be hopefully shortly available to patients at some form in the next few years.
And that's I guess kind of looking at the time, this may be the last question before I close it. But I guess to that point, one thing I didn't ask, and maybe I should have before this, is, are you routinely testing miscarriage tissue for your patients? Is that something that you recommend? And I know that's that can be a really emotional process for patients, and people can feel really differently when they get into get to the point of making that decision. But I'm curious about your opinion.
Absolutely. I think that either way, it gives you an answer. Either there's something wrong with the baby, or there's normal chromosomes and there may be something else. So I think it really helps grieving parents because I did a survey of pregnancy loss, the Hope After Loss community, to ask what was the most important need out of answers to why, family support, peer support, and reasons to prevent. And that across all groups, whether they had one loss or 4 losses, the most important need was reasons to why I lost my pregnancy. And so I think, it's a simple test where, even if they lost their pregnancy at home, they can collect the material, then we can send it for genetic testing. It will give you a answer. It may not be the answer necessarily that, we normally assume it's something wrong with the baby, but it could be that there was nothing chromosomally wrong with the baby. And then that leads us to a different path. Mm-hmm. But if there's something wrong with the baby, sort of chromosomally wise, then that can lead us to a different path. So I think it provides couples with a answer, and it's not, usually insurance will cover it. So and even if they don't, it's around $600 self-pay, that it really helps, inform for the next pregnancy what we should do, like what investigations, and it's really talking about sort of the personalization approach, because if we know sort of what is happening with this pregnancy and exclude the most common reason, which is there's chromosomally something wrong with the pregnancy, then we can move on to, okay, it's normal, let's think that this is going to be, it could be X, Y, or Z, and go from there. So I absolutely try and have my patients bring in the tissue. If they come to me as a consult, we can also request if they've collected tissue, like from a DNC, the pathology usually keep the placental tissue for a long time. So we can have those blocks cut and extract the DNA and then retrospectively find out, because a lot of people sometimes don't get the testing done. And so, we have to go sort of backwards and see if we can get that information, because it can be very informative.
Cool. Dr. Mack, thank you so much for taking this time to talk to us. I just, for everybody that's listening, like, Dr. Mack is doing this out of the goodness of her heart, right? We're not giving her anything for doing this. So thank you so much for being a volunteer and being committed to this community and to the organization. This was hugely informative. I know we covered like a really broad range of topics, kind of deep. So forward to more conversations with you to be able to focus on specific topics and go much, much deeper. But thank you so much. And for those of you that have been listening, please give the organization feedback. You can email me at megan@rplassociation.org. You can DM me. You can comment on our Instagram or Facebook page. And let me know what you thought and what you might like for future events like this. And I just want to do a very, very small plug to ask people, if you haven't joined our mailing list, please do that. We'll send updates about what the organization is doing as we kind of plan for next year and more events and programs. And then also, if you are able and want to donate, we would really appreciate any donations. We're really wanting to try and fund some important research next year so that we have more useful tools to help us all move through this process. So thank you so much, and everybody, happy holidays and have a good rest of your evening.
Well, yeah, I thank you, Megan, for putting this together. It's my first time on Instagram Live, and my goal is to educate everybody and to give the best sort of opinion with some research sort of backing. But I would say that the research in recurrent pregnancy loss is is all over the place, and we'll try and get bigger studies so that we can really sort of make a difference for our patients. So I really appreciate everybody's time who came and listened. I hope that this was really helpful, and you know, I will continue to post little things on my Miscarriage MD, and hope to, you know, continue to inform patients and help them on their journey, really.
Yeah, and that's a good point. So, Dr. Mack, there have been some questions that have come in real time, and I know some that we didn't get to. So maybe we can kind of join our Instagram accounts and answer some of the questions via posts or other ways that way, because I know we didn't get to everything. And I've seen a bunch of comments recently. Will this video be posted anywhere? Yes, I hope so. This is my first Instagram live, so hopefully I won't mess it up. But my intention, yes, is to save the recording and post it so that people can watch if they couldn't join live.
All right. Well, thank you.
All right. Take care. Bye, Dr. Mack. Bye, everybody. Thank you so much.